The next case is a 64-year-old gentleman with a background history of hypertension, chronic hepatitis B infection, violent AV fistula with embolization. He has a hereditary hemorrhagic telangiectasia with recurrent iron deficiency anemia from small bowel angiodysplasia. He has a history of prior push enteroscopy and device-assisted enteroscopy plus APC for treatment of multiple small bowel angioplastia. Last oral root device-assisted enteroscopy was done in June this year. There are multiple 3 to 5 millimeters angiodysplasias noted from the proximal to distal jejunum. About 60 were ablated with APC. He requires treatment for the residual and also recurrent angioplasia in the small bowel. This is the endoscopic picture. So today we are going to perform the balloon-assisted enteroscopy oral route plus APC by Professor Beyna.
So what is the procedure we're going to perform? So during the last maybe 7 years, I mainly performed for deep enteroscopy, power spiral enteroscopy that was provided by Olympus.
Yes.
I think you did the same, no?
Yes.
We, both of us have very vast experience with motorized spiral enteroscopy. However, this very good instrument was taken out of our hands, and now we went back to balloon enteroscopy. So we know that we have different techniques here to traverse the small bowel and to attack the AVMs that we expect here in the small bowel. So we have already here, we're in the position in front of the pylorus. You can see I have the SIF H190 enteroscope. This is 2 meters in length. We have different enteroscopes with different lengths. Here we have a therapeutic working channel of 3.2 millimeters, and we have this dedicated single balloon overtube that is connected to the balloon controller, and with that we can inflate and deflate the balloon, that we can use here the push and pull, or in this case, a hook and suck technique to traverse the small bowel. So first of all, I'm very happy that Raymond is holding the overtube for me. As you can see, this is not so convenient for him, but for me it is. Yeah. So we are now in front of the pylorus. I have, as you can see, a transparent hood attached to the tip of the endoscope, and now I push the scope forward to go through the pylorus. So the scope is a little bit floppy here. So let's push a little bit more, and now we are through. So at this point we can only push forward. We don't use the overtube at that stage because the duodenum is, and of course the proximal jejunum is fixed at the level of ligament trites, of course. So we push forward. Let's see what we can already see here. You can see some small lesions there, but maybe these lesions are not of interest in this patient. We expect larger lesions to come. So I push forward a little bit. So as you can see, we have here, this is a larger one. Yeah. So we were discussing how to go ahead. So usually using power spiral, I treated these AVMs on my way into the small bowel.
Yes.
And what's your strategy using balloons? So I would like to treat them when we go out.
Most of the time I do it when I come out, but then sometimes I notice they're difficult to treat lesions, or you think you may not be able to find it later, then I may treat on my way in. So.
So first of all, now I pushed the scope in as far as I could, and at that stage I tried to fix the tip of the scope behind that fold, and now I ask Raymond to push forward the overtube.
Okay.
This is so we lubricated the overtube very much using saline, but also with a little bit of olive oil. So then we reach here the marker on the endoscope. Maybe you can see it here.
Yes.
That means that we come close to the tip of the endoscope, and we definitely don't want to push the overtube over the tip of the endoscope. So again, I have now more scope to use. I try to see the lumen here. I suck the air from the lumen, and now I push forward. So this is now I have to do the work on my own. It's not pushing the pedal to let the spiral rotate. So I push even more. Let's get around this corner. So of course we are working with CO2 insufflation. Here, another AVM here, so get around the corner. So we are prepared here to use fluoro as well, but we both agree that we don't use fluoro in routine in these type of cases.
Right.
We more or less use fluoro when we are going for altered anatomy cases.
Right.
So here I'm just sucking the air from the lumen that even facilitates deeper insertion. So okay. So at that stage, you can see almost the entire enteroscope is inside the patient. We can once more push forward the overtube just a little bit. Okay. We have 30 centimeters left. Okay, that we can, before we do the first straightening maneuver. So the overtube is now very close to the bite block. And I again push forward here the scope. Okay. Let's see how deep we can go. We can, meanwhile, as we have identified some AVM, we can already prepare for the treatment of these AVM. And, oh, here's a nice one. Huh? Yes. You can see it on the right-hand side. Okay. We prepare for APC therapy.
Yes.
For that, we have here the Irby tower. But it's already done. Okay, first of all, we will do one straightening maneuver.
So you want to put up the balloon?
Yes,
so
we would
let's
now
put up the
like
balloon.
to inflate the balloon.
Yes. Okay, coming up.
Okay, just wait some seconds to allow the balloon to fill, because our because our plan is then to pull the small bowel onto the overtube. So we take now the overtube, I suck the air from the lumen and I pull everything out so we can straighten here the scope. You can nicely see that I gain a lot of scope length here until I feel some resistance here. Now we have a straight position again. Okay, so we have the blocked overtube, and now we have gained again a lot of scope length. I suck the air from the lumen. I hook the endoscope because we don't have a second balloon here.
Yes.
I hook the endoscope, try to hook it behind the fold to stabilize our position while we now deflate the balloon.
Okay.
Please deflate. Again, we wait some seconds. And now I ask Raymond to push forward the overtube while I suck here a little bit. As you can see, we maintain the position within the small bowel, and we push forward until we reach the white marker. And now please inflate the balloon again. Okay, again some seconds, we wait some seconds, and then I straighten again endoscope's position. We are in the lumen, and now I have again scope length to push forward. Okay, I can push, and we go forward. Huh?
Yes.
Here again. So I don't know how much time we have within this live session. Maybe we can treat one of the AVMs that we find.
Sure.
To demonstrate the principle.
Sure.
So can you hear us in the audience? Because we can't hear you.
So hello there, maybe we can treat a few AVMs here just to illustrate the therapeutic techniques here.
So we have here the 3.2 millimeter APC probe from Irby. This is a disposable APC probe that's very convenient. So we have here this Irby 300D generator that comes with the Irby APC unit. And so in these lesions, one could discuss if we can treat these lesions just with the APC probe, or do you usually inject the submucosa before you treat these lesions? We don't.
Yeah, I don't too.
Yeah. So and this is because also because the ERBI system comes with intelligent APC modes. So we have here the probe is very convenient to push it through the 3.2 millimeter working channel. So I go back a little bit to allow some space in between. So the benefit of APC is that we have a no contact method. So by this energy tension, this argon flow is formed into a plasma, and via this plasma, the energy can be transferred to the surface without any contact. So this is a big advantage here. So let's try. Maybe we can try with this setting. So always the plasma beam goes into the level. Oh, so we are close to the mucosa here. Let's go down a little bit. Let's go to 4. Effect of 4, please. It's a little bit too much, so we have to get closer to. Okay, so this was already the end here of the. Maybe we can treat this one. Okay, this is. Everybody knows very well that can be challenging. So we get. We don't want to have any contact. And here we lose now the image. If I activate the probe, here we are close to it. Okay. Yes. So this was nicely treated. No contact of the probe to the duodenal, to the intestinal wall. And using precise sect, this is the advantage is that this is an intelligent mode that regulates the amount of current according to the resistance of the tissue. So it is independent from the distance of the probe to the mucosal surface. Mm-hmm. So this was the principle. So at this stage, maybe we can again straighten a little bit. Okay.
Do you want the balloon up?
Yeah, the balloon is inflated. No. The balloon is still inflated. No?
Okay.
So we go. We straighten a little bit. I suck the air from the lumen.
So, Professor Beyna and Raymond, so what is the setting of your APC?
So we have precise APC with an effect of 4 and argon flow of 1 liter per minute.
So usually you would perform the APC during retrieval of your scope, right?
Yeah, during withdrawal. This was just to demonstrate the principle because we don't know how long we are able to.
Yes, sure, yeah. So how will you follow up this patient?
Follow up. So this patient has a known hereditary angiodysplasia. So every time this patient presents himself with anemia, there's no need, at least in my unit, we would do it like this. No need for video capsule endoscopy and other diagnostics. So every time the patient presents himself, we will do antegrade enteroscopy with APC here.
Yes. Yeah, same here too.
Yeah.
Yeah.
So again, here you can see we again have straightened the scope. Okay, I again suck the lumen. I bend the scope to hook myself here into behind the fold, and we deflate the balloon. Wait some seconds, and then we can push forward.
Deflate 咗啦，係咪 deflate? Balloon down, right?
The balloon is down, yeah.
Balloon is
yeah.
down. Okay,
Okay,
going
push
in.
forward. Okay, that's enough. Then inflate the balloon. Again, we wait some seconds. Okay, then I release, and again, so this was suction of the mucosa. This is no AVM there. So I push forward, and then hopefully we can go around this corner. Yeah, so, yeah, obviously we are in the same position as before. So enteroscopy is now a little bit more stressful for us. Huh?
Yes. Yeah, we missed the days of the power spiral.
Definitely. Okay, so maybe to get a little bit further, we can deflate the balloon and push forward this, the last part of the overtube.
Okay, I'll wait for the
Yeah.
deflating.
Now it's deflated, and then push
I'm
forward.
ready. Okay.
Okay, and inflate the balloon. Thank you. sometimes this is helpful to get around the corner, and then we can hook ourselves in and pull back again. Okay, let's see. Yeah, now it's working very well. So the last time you did this procedure in the patient, you used power spiral.
Power spiral, yes.
How far did you come?
Maybe the distal jejunum, but I stopped due to the time limit, not because the machine couldn't go further.
Yeah.
I think we get a higher total enteroscopy rate with that unit. So.
Definitely, yeah. So this patient is lying on his back, so in the supine position, but it's not intubated.
Not
The
intubated.
patient is no intubation, so there's definitely a time limit, no?
Yes.
Doing so. Okay, we have the inflated balloon, and again, let's straighten.
Yes.
I will pull it out. I try to hook ourselves here behind the fall. Pull back. Okay, now I feel resistance. And again, I hook the scope. Okay, deflate the balloon. Okay, now we have deflated the balloon. And you can, okay, then we can push forward.
Okay. Balloon
The
down,
overtube.
right?
Yeah, balloon is down.
Okay.
We push forward.
Yes. Okay.
Okay,
Okay.
that's
so-
enough. Okay,
yes.
inflate. And I wait again and allow the balloon to fill again. Okay, and then I again push forward. Yeah, nice.
Professor Beyna and
Yes.
Raymond, thank you for showing us the way to perform single balloon enteroscopy and also APC, the technique of APC.